So, ma'am, it's 3, 2, 1. Over to you.
Hello, friends. Good evening and a warm welcome to this obstructive airway disease webinar series from ICS under the leadership of Dr. Sandeep Salvi, Dr. Amitan Nenne, and Dr. Rajadhar. So, today we will be speaking about phenotyping of bronchiectasis and revolutionizing the management. And to take forward this session, we have eminent speakers and panelists for the day. So the first, there will be a talk on phenotyping of bronchiectasis, a complete review by Dr. Deepthi Goti. Can I have the introduction slides, please? And apart from that, we have, you know that Dr. Deepthi Goti is a professor and head Department of Pulmonary Sleep Medicine and Critical Care at ESI PGIMER, Delhi. And she has got a special interest in running the DM program in pulmonary medicine since 2017, and she has got over 125 publications and more than 70 lectures in national and international conferences, as well as many chapters in the book to her credit. I don't think ma'am needs an introduction. She has been a mentor for many of us. And apart from this, we have an exciting panel discussion on questions that we face in our day-to-day practice. And in our panel, we have Dr. Makesh P. Can I have the introduction slide, please? So, Dr. Mahesh P. sir, as we all know, is a professor in pulmonary medicine in JSSMC, Mysore in India. For anybody who is from Karnataka and from southern part of India, and even for that matter throughout India, we all know sir as an excellent academician, person of repute with a keen interest on research. And sir has got more than 362 original articles, publications, and international, which include international publications of 329, which is a huge number, and H index publications as high as 81, and that should be an inspiration for many of the youngsters here. Apart from that, he is listed in the top two of all researchers in the world in the year 2020, 2021, 2022, 2023 by the Stanford University, USA. And he has got a lot of awards and credits. The list goes on and on. I think we need another webinar to speak about the list of achievements by Dr. Makesh sir. So I think he doesn't need much more introduction. We all know him as a great teacher and as a friend, as a person of repute from our fraternity. And along with this, we have Dr. Girija Nair. Can we have the introduction slide of Dr. Giriraj Nair, please? So Dr. Girija Nair has done an MBBS in 1985 and she's a MD TB and respiratory disease, and she's currently heading as the professor in the Department of Pulmonary Medicine at D.Y. Patil Medical College and Hospital in Nerul in Navi Mumbai. And ma'am has been known for all her academic activities and for training all the postgraduates. And we do see a lot of postgraduates coming from Mumbai who speak volumes of about her academic interest and achievements. And welcome to the panel. Welcome to the webinar as a part of a panelist, ma'am. And next, we have two young pulmonologists who are joining the panel discussion. We have Dr. Mahesh Jansari. He is working as an associate professor in the Department of Pulmonary Medicine at AIIMS Kalyani. And I had a brief interaction with Dr. Mahesh, who had come here for our fellowship program, and a gem of a person and a true academician. And today he will be joining us as a panelist in the panel discussion. And last but not least, we have Dr. Kushbu Saxena. She was also a part of a fellowship, was also a part of our fellowship program at Ashoda Hospitals, and right now she is doing a great work in the field of interventional pulmonology as well as in the sleep medicine. And she has also received her postdoctoral certificate course in sleep medicine at AIIMS Mopal. And she is currently working as a consultant in the Department of Pulmonary and Sleep Medicine at Apollo Sage Hospitals in Bhopal. She has got numerous publications, and we all know that she was an extremely hardworking student, but right now she is a teacher by herself, disseminating knowledge across to all the young pulmonologists throughout the country. So, without wasting much of the time, I would like to request Dr. Deepthi Goti ma'am to deliver a talk on phenotyping in bronchiectasis, a complete overview. Yeah, over to you, ma'am. I think Dr. Deepthi, ma'am, you're on mute.
Just hold on for a second. I don't know, it was already shared and it got unshared. Yeah. Yeah, I would like to take a little liberty and make it into precision medicine, because more than advances, I really want the diagnosis and management overall to be precise in bronchiectasis case. It's a term which is very loosely used, and even treatment is even worse loosely used. What happens is that I happened to take a round with one of my senior residents, and she said, "Ma'am, this is bronchiectasis." I picked up the CT scan, and I saw there was one chintu bronchiectasis. I really want to use the word chintu because it really gives an emphasis to the word small bronchiectasis. Small bronchiectasis was somewhere somebody had labeled it as bronchiectasis, and it went on as bronchiectasis. So what is the treatment you are giving? The chest physiotherapy was not given. So not even the fact that the term was not rightly used, the treatment also was not rightly used, and this happens very, very often in clinical practice. So I really want to make sure that everybody understands when to use the term bronchiectasis. Now, this particular problem of bronchiectasis and a misterminology is basically because you have a definition given by Lennet in 1890, which said that there is a bronchial or airway distortion and there is a permanent dilatation. Now, from the radiologist perspective and radiologist point of view, abnormal and permanent dilatation of bronchi is fair enough. They see 1-2 bronchiectasis, they may report it. However, that bronchiectasis, how important it is and how clinically relevant it is from the patient's management perspective is for us to decide. And we used to be taught the fact that you have a triad of suppurative lung disease, crackles and clubbing, you call it bronchiectasis, likely to be bronchiectasis. That one needs to understand that there is a difference between a radiological definition and clinical disease. The person you have is both with the radiology and the clinical finding, and one needs to use this terminology appropriately. So, for example, in this case, left first slide, you have a traction bronchiectasis on the first one. And that bronchiectasis, this cannot be called, this is an ILD patient. Now, here there is an air trapping, and on the air trapping on the right first corner one CT scan, air trapping, and there is a dilatation of bronchi. Probably this is a dilated bronchus because of secretion retention, and mainly the patient has obstructive airway disease. Again, over here, there are some centrilobular nodules. There is some bronchiectasis. One needs to make sure that it is not NTM or it is probably an obstructive airway disease. Same over here. This looks like right lower one. This looks like post-tuberculous bronchial dilatation, and this cannot be really labeled as bronchiectasis. What can be labeled as bronchiectasis when you see something like this on CT scan? Yes, you would say that yes, there is a definite bronchiectasis and the patient may be having a symptom. But at the same time, one needs to understand that there is no typical patient of bronchiectasis, and no two patients of bronchiectasis are same. One will have a difference from other in terms of the place of involvement of bronchiectasis, the extent of involvement, associated finding, the cause, the microbiology. A lot of difference is there from one patient to another, and one needs to define a patient properly. Before actually going into the clinical part of the bronchiectasis, I would like to introduce you briefly to what is called as a radiological scoring. Now, this particular scoring, which is called as a Bhalla score, it's a very complex one, and I don't really use it. It has maximum score of 21. But if you see a simple one, which is called as a BRIC or bronchiectasis radiology index, CT score, and this particular one, if you see, it is very easy to understand, very easy to implement. None of our radiologists really, define bronchiectasis with respect to the extent and severity of bronchiectasis. You just describe one terminology and leave it at that. If they have something like this in terms of if you have a severe lumen third 3 times the diameter of the vessel, or you have a mild and moderate obstruction, dilatation of bronchi, and how many segments are involved. So maximum score out here is 3 plus 5. And if there is a 5 score, then you would call it a severe bronchiectasis. So if we train our radiologists in terms of defining bronchiectasis with respect to severity, it would help us, it would help treat our patient better. Even if the radiologists have not defined, it is our duty when the patient comes to us to define the patient's severity in terms of either what is called as a bronchiectasis severity index or what is called as a FACIT. Again, over here, I would pick up the simple one, which is called as a FACIT, because we are all busy practicing or teaching or something or the other, and it is very difficult for us to remember complicated, scorings. So this BSI is the original one, and it is definitely has a edge over FACIT, but in a head-to-head clinical trial, they are more or less similar. If you talk of BSI, it has a 9 variables, and of these 9 variables, the first 5 variables of BSI are same as this FACIT, and FACIT is very easy to remember. When you talk about BSI, it has 25 scores and more than 9 is severe. One can use an online calculator, so I'm not going into the details of it. However, when you're talking about FACIT, it's very, very easy to remember. Like right after this lecture, you can easily recollect and remember that F stands for FEV1, FEV1 more than 50% or less than 50%, 0 score or 2, age more than 70 and less than 70, again 2 or 0, pseudomonas again yes or no, 1 and 0, radiological extent of the disease, more than 1, more than 2 lobes, 1, and 1 to 2 lobes, 0, MMRC or dyspnea scale, and if it is 3 to 4, it is 1. So more than 5 to 7 is a severe one, and if the patient has a severe disease, you need to score it down, say that it is a severe bronchiectasis, not like the one I gave an example that there is one small chintu bronchiectasis. So one needs to make sure that the severity is defined. Now, coming to a little more complicated thing, this particular was given in one of the chest journal. It is called as bronchiectasis fingerprinting. If you try and do this fingerprinting, you would take easily half an hour to 1 hour. So in somebody who is running a busy practice, I would not really state it, but this basically diagram represents the complexity of bronchiectasis that one can have, and is actually a complex disease or a disorder. It is not a simple disease. It is a multitude of problems, and there are multitude of treatable traits that one needs to know, which is a center point of our today's discussion. Now, what is this multitude of problem and multiple vortex that it carries? It carries, one is the structural damage. How much is the structural damage? Whether this structural damage will go on or no. This was one of the recent AJR-CCM article. I will give the details of it a little later after 2-3 slides. But basically, there are 4 possible vortex which describes and defines a syndrome of bronchiectasis with multiple facets in it, and that's why it makes it a syndrome. That's why it makes it not 2 particular patient would be the same, and that's why it needs today's lecture to define each patient properly. So you can have a structural damage. How much is it and all? We just discussed it. One can have epithelial or ciliary dysfunctional predominant symptoms. One can have inflammation in terms of either neutrophilic or eosinophilic, or in terms of infection. I would take each one separately through it. Before I go into the depth of each one separately, I would just give you this is what I was telling you. This is where I have taken this today's main lecture from, which has really, when I read this article, I was really touched, and I said, we must have a webinar on this, because this aspect is not touched upon in most books and in most places. And it really gives an emphasis that when you have a clinical problem, clinical problem can be also in terms of exacerbation. How frequent are the exacerbation? Does the patient have any obstructive airway disease or no? If the patient has frequent exacerbation, I will cover up. This is going to be covered 2-3 times in this lecture, so not going into the detail right now. One can have excessive mucus secretion and plugging, etc., especially cystic fibrosis or otherwise, and one can use airway clearance techniques or mucolytics or hypertonic saline and NAC. There are 2-3 options available. Even a newer mannitol, inhale mannitol is coming up in a way. You can have etiological conundrum or etiological diagnosis, which will again have a multiple facets in terms of whether it is a hypergomaglobulinemia, whether it is cystic fibrosis, whether it is immotile cilia syndrome, alpha-1 antitrypsin, whether the patient has connective tissue disorder or irritable bowel syndrome, inflammatory bowel syndrome, ABPA. So the list goes on in terms of the diagnosis, and one needs to have a proper diagnosis. Then only one can treat. You can see that various possible options are there in terms of treatment if the diagnosis changes. So it is very important for us to find out what's the diagnosis of bronchiectasis. Inflammatory facets are also 2-3. Mainly it is 2, neutrophil and eosinophil. One can find out how one has a whether one has a neutrophilic inflammation or eosinophilic. Again, we'll cover a little later. Or if the patient has any microbial, colonization in terms of Pseudomonas, NTM, Aspergillus, Klebsiella, and deal with it accordingly. Or geographic location, Klebsiella, etc., is found more commonly in India. And NTM again in the South American region. So various facets are there, and we'll cover one by one slowly. When you are talking about the phenotype in terms of etiology, now there was one very large study called EMBARK, India cohort, and what they saw was fewer than 5% underwent a recommended etiological testing. So in India, there is no particular concept of finding out why the patient has bronchiectasis. That question is not asked only. Bronchiectasis, okay, fine, go ahead, treat. You treat what? One important aspect is that the treatment will depend on what the underlying etiology is. And etiology can be in terms of immunoglobulin deficiency. One can treat with a replacement therapy. It can be in terms of ABPA, would have a proximal bronchiectasis. Of course, asthma line of management plus steroid. Alpha-1 antitrypsin deficiency also. I've hardly ever seen anybody really working for alpha-1 antitrypsin deficiency when they have seen bronchiectasis. Cystic fibrosis is treatable too. There are CFTR medicines which are available, and these are really, they work well. NTM is often overlooked. Inflammatory disorders like bowel disease, inflammatory bowel disease need steroid. Bronchiectasis would, shudder to give steroid, but in inflammatory disease, yes, you need to give steroid. Primary ciliary dyskinesia is again a bit, this is out of all the diseases just labeled, primary ciliary dyskinesia is the only disease which is a little difficult to diagnose because one needs an electron microscopy, and electron microscopy would, confirm the diagnosis. However, rest of the things can easily be diagnosed and should be diagnosed and should be, looked for in most cases. The center question, that is why the patient has developed bronchiectasis. If infection is ruled out and all other diseases are ruled out, then only one can label it as idiopathic bronchiectasis. Again, when you're talking about phenotype, one needs to know whether the patient has come with a breathlessness. I used to have a typical patient where patient had hemoptysis and breathlessness. Patient actually had bronchiectasis, but her phenotype was that of obstructive airway disease, more common, and her breathlessness or her cough because of obstructive airway disease was leading hemoptysis. when the patient was treated well with inhaled bronchodilator, and in this case, she was also requiring inhaled steroid. When she was treated with that, then only her hemoptysis stopped. So hemoptysis treatment and management would only depend on or based on what the cause of hemoptysis is. It's just the bronchiectasis, or there are multiple other factors related to it. If the patient has mucus hypersecretion, as I just discussed, that hypertonic saline or using DNS or newer drugs like mannitol, etc., would be NAC, all of us know, so would be more useful in these patients. Rhinosinusitis, again, it's a common triad. They have rhinosinusitis, they have suppurative, both together will feed one another, and when they feed one another, one needs to treat the first part also, that is rhinosinusitis part. Polyps, gastroesophageal disease, they commonly have depression and anxiety, which needs to be looked into. Sleep is often affected, and cardiovascular diseases or low BMI are often there. So this particular, it's not just one thing that you look at, cough, expectoration, and treat with that. You look at the multiple facets in terms of what the symptoms are of the patient. Now, this is a classical patient where the patient has, if you see, that there is lower lobe cystic lesion. Now, this cystic lesion is here. So, this particular patient came with obstructive airway disease, bronchi kind of a thing, but CT showed this. CT showed this and X-ray showed this. If you see this, there is a presence of mosaic pattern, and this mosaic pattern, this is primarily obstructive airway disease. Now, as Hansel et al., he is a famous this CT scan who defined post-infections. He said, when there is an infection, one can have either a bronchiectasis or obstructive airway disease, or both. Whichever is predominant, one has to describe as that. So in this patient, if the patient has come with an OB pattern or obstructive airway disease, it actually goes into a management of obstructive airway disease much more than this. But at the same time, the patient will require a lower lobe chest physiotherapy and drainage, which is also an essential center point of this particular patient. Needless to say, this patient had actually a liver disease history, and in the son, and young son died of liver disease. So one needs to rule out alpha-1 antitrypsin 2 in something like this. Now, I would like to give one more example where this patient was, you can see that the patient has a pneumonectomy done. I know the history, so I can tell you that the patient was treated with pneumonectomy for his bronchiectasis. Without realizing, the patient had an obstructive airway disease in the other side. Now, this dilated bronchi giving rise to continuous pseudomonas infection. At the same time, this patient is respiratory crippled. He has anxiety, he has depression, and he is lying in the ward with a permanent disability in terms of continuous bronchoria, continuous bronchial secretions, recurrent infection, and dependent on both NIV and LTOT. So before subjecting the patient to a severe form of management in terms of surgery or lobectomy or pneumonectomy, one must make sure the patient has the obstructive component, and if the patient does not have the obstructive component, then only one should go ahead and do something like this. With two examples just to show you that there are different forms of disease and different manifestation of the disease. Now, another facet of phenotyping is that there is an inflammatory part. The inflammatory part can be either a neutrophilic or eosinophilic inflammation. Most of the cases are neutrophilic inflammation, and they usually have sputum purulence or volume, which is a problem with them. And one can use what is called as neutrophil elastase, though not easily available, in terms of the diagnosing whether it is a neutrophilic inflammation. Though, as I said, that neutrophil elastase is not available easily, at least you can do a sputum examination and check what is the neutrophil of the patient, or whether it is neutrophil predominant or not. If not, at least one can find out very easily that if the patient has eosinophilia, patient has higher sputum eosinophil, patient has high IgE, or if the patient has high FeNO. If the patient has all this, then he is likely to be an eosinophilic inflammatory phenotype. And if it is that, then one needs to add drugs appropriate for that. So if you phenotype in terms of neutrophil and eosinophilic, it helps in management the patient. How does it help in managing the patient? If it is neutrophil inflammation, the patient can be given long-term macrolide treatment, maybe 3 months, maybe 6 months, but at least it will reduce the inflammation. There are newer drugs which are available, which are called as cathepsin inhibition, cathepsin C inhibition, or dipeptide peptidase 1 inhibition. These are novel anti-inflammatory therapies targeting neutrophil serine proteases. The good part about it is it has completed the phase 2 trial very successfully, and it basically helps in balancing protease anti-protease activity. So protease and anti-protease activity is something which needs to be looked into. If you have a high protease, then anti-protease is supposed to inhibit this high protease, and this particular drug, what is called a brensocatib, is helpful in doing so. So we are eagerly awaiting the phase 3 trial results. Hopefully will be out in 2-3 years. So that is about the neutrophilic inflammation. Now, if the person has eosinophilic inflammation, one can of course use inhaled steroid, but not only inhaled steroid, anti-IL-4 and anti-IL-5 are the drug which can be used and which have been tried in cases of bronchiectasis to prevent recurrent exacerbation. If the patient has a phenotype in terms of a colonization of bacteria, it is very, very essential in a patient, especially who has recurrent exacerbation, or even if they don't have recurrent exacerbation, one sputum examination is hardly anything. A good sputum examination, they bring out sputum very easily. So single organism isolation in terms of Pseudomonas also confers a bad prognosis, and therefore eradication is important whenever possible. Whenever possible, I said, because it's difficult to eradicate Pseudomonas, and it's almost 40 to 50% times that it is possible to eradicate. Rest of the time it is not possible. But whenever possible, please try and eradicate. If there is NTM infection, of course, follow the guideline and treat as NTM. The radiological finding of middle lobe bronchiectasis and nodular opacity help in understanding that there is possibly that the patient has NTM infection. Aspergillus itself is associated with sensitization, and in ABPA also can be having Aspergillus associated. So ABPA will be covered a little later, but one needs to understand that there is isolation of Aspergillus itself does not mean anything. One needs to confirm with the help of multiple tests. So the multiple tests that one can confirm it with is CRIM. That is clinical, radiological, immunological, and microbacterial. And if the CRIM is positive and the patient has either COPD or post-TB, then treatment in terms of itraconazole or voriconazole is important. On the other hand, if you have a Pseudomonas colonization, as per ARS guideline and otherwise, it was not very clear as to what to give to the patient. There are multiple different opinions given, but one of the recent meta-analysis states that one may not repeat a sputum once you find a colonization. Systemic antibiotic for 2-3 weeks, either in terms of IV or oral, followed by inhale antibiotic in terms of Tobra, Genta, or Colistin for 3 months is something which is recommended and highly recommended for patients of Pseudomonas. So if you find Pseudomonas, please try and treat it, because this will really improve the quality of life of the patient and prevent repeated exacerbations. So I would like to summarize it. I guess I'm running out of my time of 20 minutes. Radiologically, if bronchiectasis is described, it does not mean the patient has bronchiectasis clinically. One needs to go into the depth of the history and define that what kind of bronchiectasis it is, because no two patients of bronchiectasis are the same. There is a clinical and radiological severity indices. These need to be identified and described as per the patient's need and patient's severity, because this is what decides the further management of bronchiectasis. Last but not the least, for which we actually conducted this particular webinar, is it's a syndrome. And there are treatable phenotypes like various etiology, like clinical definitions, and clinically whether there is hypersecretions, recurrent atrial agitation, hemoptysis, dyspnea, etc., or inflammatory phenotypes in terms of neutrophil or eosinophilic predominance, or microbiological precision in terms of whether the patient has pseudomonas or any other colonization, should be sought for. Thank you. This is my hospital. Thank you. Over to you.
Dr. Dipti, you have actually described very much in detail, and it was really an excellent presentation, I should say. The way you have described the etiology, clinical features, and described it as it's like an inflammatory vortex kind of thing. Not only a vicious cycle, but it's a vortex which will just bring you as well as the patient into it. So the patients, each bronchiectatic patient is different actually, and we have to basically, it's a final end point of all that inflammatory and all the problems that are happening in the patient, and what is the cause, to identify it first and then treat the cause rather than only treat the end point. That should be our main aim. With this, definitely you have just described very much in detail. I hope all the attendees have really taken advantage of your presentation. With this, I will introduce Dr. Vishweshwaran Balsubramaniam, and we can maybe start our case discussions. We can start our discussions. Dr. Vishweshwar doesn't require any introduction. He's one of our, he's a gold medalist from Safdarjung, and he's a young, dynamic person, and I think most of us have seen him at different places. Yes. And he has done his DM in pulmonary and critical care medicine, and he's a gold medalist from Safdarjung Hospital. And he's a fellow in advanced intervention pulmonology. He's got his fellowship from Malaysia. And he's also got the European Diplomate in Adult Respiratory Medicine from Switzerland. He's got more than 30 publications in national as well as international journals. He's a course director in Advanced Interventional Pulmonology fellowships at Yashoda Hospital and Somaligoda. And he's a reviewer of Lung India. He's a member of the nebulization guidelines also member, as well as he's a program director and mentor also in intervention pulmonology. And he's one of the top pulmonologists at present. It's a great introduction for a young dynamic person. And with this, I think we should be starting our discussion. Over to you, Dr. Vishwesh.
Thank you, Dr. Girijan Ironman, for the pleasant introduction. And thanks to Dr. Deepti Gothi ma'am for highlighting on all the practical points in the phenotyping of bronchiectasis. So without wasting much of the time now, we'll move on to the most exciting part of the day, that is the panel discussion. So my first question is to Dr. Makesh sir. So how common in your clinical practice, in your day-to-day clinical practice, do you encounter bronchiectasis? And if you have to say the most common... Pardon, sir?
Yeah.
Yeah, and if you have to say, like, what could be the most common etiological reasons you see in the patients of bronchiectasis presenting to you?
Sure, yeah. Thank you. And we had a very nice talk by Professor Deepti. So about 2 to 3% of the patients would have bronchiectasis in the OPD. I'm in tertiary care. It may not, and in a medical college, it may not reflect what other people see, but it is roughly around that. And we were part of the EMBARK study that was done in about 31 centers in India. We were part of that. And roughly you can say that 1/3 of the patients is due to tuberculosis. They have post-tubercular sequelae. One of her PGs just completed her thesis in which she followed up prospectively the patients who started on TB treatment And 66% of them ended up having some radiological abnormality. So even though you start, the treatment is successful, the patient with 1/4 of the causes was due to other infections, non-tubercular infections, pneumonia being the most common. Childhood respiratory infections were also there. Even pertussis was also identified in the EMBARK study. 1/5, that is about 20%, is idiopathic. 9% was about ABPA, about 5% COPD, 2.5% asthma, and less than 1% was and non-tubercular mycobacteria. This is roughly the load and the common etiologies identified in the EMBARK India study.
Yeah, so that's very, very important point put forward by Dr. Makesh sir. So in India, TB or even in TB endemic region, TB continues to remain one of the important reasons of bronchiectasis. But apart from that, whatever Dr. Makesh sir has said, sometimes you may encounter bronchiectasis even as a part of your systemic abnormalities like IBDs and other alpha-1 antitrypsin deficiencies and so on as well. So now moving on to Dr. Girija Nair, ma'am, what are the important points in the history and the clinical examination that will help you to clinch the etiological diagnosis of bronchiectasis? Do we have something like that, or it should be always an investigation-based diagnosis for the etiology?
No, initially, definitely we have to take the history. Because as the previous Dr. Dipti ma'am also said, it is like the causes of bronchiectasis basically could be congenital or acquired. That's what we used to say. It is similar to what we are also saying at present. So age at presentation, if a person is presenting with cough and, from childhood itself, we have to think of the congenital causes like, maybe cystic fibrosis or your hypogammaglobulinemias and all the other childhood infections, the congenital things. Then in our country, like Dr. Mahesh has just said, so childhood infections form a very important cause of this bronchiectasis. So we have to ask history of repeated childhood infections, history of tuberculosis. So these are the main, other things. And comorbidities, we should ask them as in the history, because as Dr. Dipti has very in detail, she has described, what are the different traits also, like, GERD the patient will have, rhinosinusitis, depression, anxiety. So this all will come in history. That may also help, rhinosinusitis again, whether asthma or even COPD is the cause of the bronchiectasis. So this will help in identifying the etiology of the bronchiectasis. GERD again, as we have said. Then the other history that we would take is other symptoms like etiology or history also we can take. Previous, if the patient has had Pseudomonas infection. So if previously he has been diagnosed as having Pseudomonas, there's a good chance that he can have a Pseudomonas infection again this time. So all these secondary infections that the patients have, it's not only one organism that may be there. So in the history taking, we should take the history of what previous exacerbations the patient has had. And clinical examination, what you can generally, clubbing is always there in most of our patients. But whether the patient has had respiratory failure or the patient is having a low BMI, again, and anxiety, depression, all this history should be taken, and then we go for the diagnosis. And that's how we will be able to treat the patient. It is not only a single disease, it is a syndrome, as Dr. Dikti has said. So the identification of the etiology will help in the management of the patient.
Yeah, thank you, Dr. Girija Nair, ma'am. And as ma'am has rightly said, it's a syndrome. And when we say about syndrome, it is not limited to one particular lung alone. So when we speak about bronchiectasis, it's more of a systemic disease. Sometimes you can see a patient of bronchiectasis presenting with renal failure, possibly because of amyloidosis. And sometimes the patients of bronchiectasis can also present as a part of a systemic manifestation, as we saw in autoimmune conditions and other things. So I think having a holistic examination of the patient, starting from his sinus, starting from his nose, looking into his oral cavity to find out reasons for aspirations, and even nicotine staining of the teeth, and looking into other clinical features in the chest. So it should extend across all the organs rather than just being limited to the lung, because we are dealing with possibly a syndrome. So this takes us to the next question to Dr. Makesh. So we speak about bronchiectasis. So how do we actually define a bronchiectasis? Because sometimes radiologically you may see something which mimics a bronchiectasis. And once you start defining a bronchiectasis, what are the pathophysiological mechanisms which are involved in the process? Over to you, Dr. Makesh. You are on mute. You are on mute. Kindly unmute.
Dr. Deepti ma'am has mentioned the definition of bronchiectasis as an permanent irreversible dilatation of the airways. And I still remember the definition which I had mugged up during my PG days, that it is an abnormal permanent irreversible dilatation of medium and large size airways due to injury to elastic and muscular tissue due to defective cilia, and it clinically manifests as cough with expectoration, which is copious in amount and which is postural dependent. While defining the bronchiectasis, we should also know about what is pseudobronchiectasis. Actually, pseudobronchiectasis is usually seen in the post-pneumonia, and it is a reversible type of bronchiectasis, and it resolves by the 6 months after the treatment. And mainly, this is seen in children. As you have asked about the pathophysiological mechanism, historically, the pathophysiological mechanisms have been defined by the Cole's hypothesis, and it involves the environmental insult in a genetically susceptible individual. It causes the infection, and this infection leads to an mucociliary dysfunction. Mucociliary dysfunction causes a cycle of infection, inflammation, again destruction, and this leads to permanent dilatation of the airways, and it manifests as a bronchiectasis. And as Dipti has mentioned in her talk, that this is a vicious vortex rather than a vicious circle.
Yeah. So the important take-home message for the audience here is, previously we used to call it as a cycle, that it starts as an insult, inflammation, infection, damage, and again colonization. But now we move on to a terminology called as a vicious vortex. So it essentially means that it just gets itself into a loop, and as the loop gets extended more and more, the damage is going to keep occurring more and more. And another important point which Dr. Makesh brought about was pseudobronchiectasis, because this is something which you will see very often. Patient, when you get a CT scan for an underlying pneumonia, you feel like a bronchiectasis like change. But on subsequent treatment and follow-up, you see that most of these peribronchial inflammation settles down, and the patient don't have any sort of a residual bronchiectasis. So these are some practical points which we should be aware about. And I think rather than calling it as a cycle, calling it as a vortex would be the new age norm for the pathogenesis of bronchiectasis. So over to you, Dr. Kushpur, like what are the radiological presentations of bronchiectasis, and how can it give you a clue to the underlying etiology? So we all know that it's more of a CT diagnosis, but are there any particular patterns of presentations in the CT, and can it predict any sort of a particular etiology or prognosis for these patients?
Thank you, Dr. Vishwesh, for having me here. First of all, whenever we feel like the patient is having bronchiectasis on the basis of history, we would first screen the patient for with an X-ray. So X-ray might be showing certain non-specific findings, but X-ray shows findings when the findings are really gross. So if you are their suspicion index of suspicion is really high, then you should rather go for HRCT scan, which is confirmatory and remains the mainstay for the diagnosis of radiological diagnosis of bronchiectasis, wherein we can find certain parallel linear densities, tram track opacities, ring shadow, reflecting thickened and abnormally dilated bronchial walls, which is also known as signatric appearance. More so, we also see for broncho-arterial ratio, which is defined by the ratio of inner wall of airway with the adjacent pulmonary artery branch, and the ratio more than 1 is usually diagnostic of bronchiectasis radiologically. Also, one can find non-tapering airways, and to define that, one should find the airway should remain unchanged for at least 2 centimeters distal to the branching point, And also airway detected in periphery of the lungs, like 2 centimeter away from the costal pleura, is also regarded as abnormal and a sign of bronchiectasis. Along with that, one can also see certain ancillary findings of HRCT in HRCT, like bronchial wall thickening, mosaic attenuation pattern, airway trapping on expiratory HRCT scans, mucus plugging in large airways, small airways, and also certain sometimes you can also find interlobular septal thickening. So these are the gross findings which one can find on HRCT scan of bronchiectatic patient, but there are certain specific findings which are which gives you the clue, or rather diagnostic clue to confirm the etiology. Like in ABPA one can find HAM, high attenuating mucus impaction, and also central cystic bronchiectatic pattern. Other than that, other systemic diseases also should also be ruled out, like rheumatoid arthritis, wherein you can see um, bilateral involvement and peripheral bronchiectatic pattern. Also in aspirational patients, like patients who are having Parkinson's and other diseases, who are having aspirational pneumonia, you would find pneumonia in the specific site, like right lower lobe. If we talk about the rare diseases, then tracheobronchomegaly will also show certain specific signs, like dilatation of trachea along with the airways overall, along with the bronchiectasis. So these are certain things which I can enumerate right now.
Yeah, thanks, Dr. Kushbu. So, as Dr. Kushbu said, when we look into a CT for bronchiectasis, it doesn't mean that we just diagnose bronchiectasis. It can give you a lot of clues, and most of these bronchiectasis also coexist with broncholectasis. That means they also tend to involve the smaller airways. And when you find bronchiectasis predominantly in the upper lobe, more of a central distribution, then always have in the back of your mind to screen for an ABPA. And if the patient comes in a pretty early age group, then even cystic fibrosis can present like this. But the most important thing about the bronchiectasis is, if you see a bronchiectasis localized to one particular lobe, then always think about some sort of a endoluminal obstruction. It can be a retained foreign body, or it can be some endobronchial tumors, which has caused recurrent post-obstructive pneumonias, which has caused the bronchiectasis. And apart from that, as Dr. Kushbu has also already said, you can see the bronchiectasis as well as a spectrum of ILD, where you tend to have more of these traction bronchiectasis. And right now, the guidelines have changed. Even with one layer of honeycombing, like one layer of traction bronchiectasis, you can still have a possibility of honeycombing as well. So I think when we look into the CT, our thought process should be beyond just diagnosing bronchiectasis. We should try to understand what could be the potential etiological aspect, like looking into the ham and other things as well. So with this, we move to Dr. Deepti Gothi. So how do you, we spoke in depth about phenotyping of bronchiectasis in the presentation, but how in real world clinical practice do you actually phenotype your bronchiectasis patient, and how does it actually impact your treatment plan?
So I definitely do. One thing is the history, as everybody has described history. Two things which are remaining: the sibling death in the family, history of, like yesterday only I saw one patient of bronchiectasis. Her son had died at 7 years of age with cirrhosis of liver. It automatically connects to alpha-1 antitrypsin. So the family history is one part, history and infection history, etc. The other part is, of course, CBC, IG, etc. Pheno also. This patient, I would get a pheno done because if there is an inflammation, one would like to give inhaled bronchodilators and inhaled steroid, etc. Sputum examination in terms of culture, sweat chloride test, of course, whenever possible and whenever is thought of. Immunoglobulin deficiency is done in almost all the patients that I see by and large. Only thing, as I said, that nasal mucosal biopsy is difficult, but sputum examinations for AFB examination, etc., is very much doable in terms of patient management. Ultrasound abdomen, one of the patients of cystic fibrosis was defined when we saw calcification in the pancreas, and we said, oh, this looks like cystic fibrosis. So one Another important investigation, I would say, CT scan I would done for obstructive airway disease, OB, and for postural drainage. Nobody has spoken, including me, has not spoken about postural drainage. It's the most important aspect. Till date, I define and give postural drainage to my patients myself, both in bronchiectasis and lung abscess. So lower lobe, head down and multiple positions. I'm sure all of you all can look up, but postural drainage is something which I always do in these patients. And mucolytics, etc., inhaled steroid, etc., and antibiotic based on the colonization, aspergillus sensitization, aspergillus antibiotic. So multiple treatment modalities are there, and vaccinations, etc. So these are the ways that I would manage my bronchiectasis, not to forget postural drainage. I mean, all my students know that I will do it myself if they don't do it.
Yeah, thank you, Dr. Dipti ma'am. But for the interest of the audience, so just like how we phenotype asthma or how we phenotype COPD, now phenotyping for bronchiectasis is very important because we are moving into the era of precision medicine. So just to make it simple, what Dr. Dipti ma'am has said, at least you need to know whether you're dealing with a CF bronchiectasis or a non-CF bronchiectasis or a frequent exacerbator phenotype. So these are the three well-established phenotypes. But if you go into depth, now people have even started finding out whether it is a neutrophilic predominant bronchiectasis or an eosinophilic predominant bronchiectasis, where if it is an eosinophilic predominant bronchiectasis, you use the pheno just like you use it in an asthma, or because these play a very important role in choosing whether you want to choose a long-term azithromycin or even a biologic for a bronchiectasis patient as well. So we are moving more and more into the era of precision medicine. But one thing in India, always remember, any patient with a bronchiectasis, never forget, especially if they have a history of an asthma, never forget to screen for ABPA. It is very, very common. Until and unless we actually screen for it, we miss the diagnosis of ABPA, and many of these patients tend to land up in a respiratory failure at a later stage. So always look for ABPA, and any patient with a post-TB, at least at the end of treatment, try to get some sort of a radiological investigation to see whether they have developed any sort of sequelae secondary to the tuberculosis. And if needed, do a pulmonary function test to look for any sort of an airway involvement. So that is how the era of bronchiectasis management is going to change, and we may see more drugs because we are moving into the era of precision medicine. So with this, now we'll move to Dr. Makesh. What are the baseline investigations which you feel is of importance, especially in a patient with a non-CF bronchiectasis for making a diagnosis? Do you limit only to HRCT, or do you get a battery of serological investigations? Because we know that even for immunodeficiency, there are certain treatments available.
We mainly, actually deal with the adults. And I would classify the diagnosis that we do into subgroups. One is you want to make a structural diagnosis, that is using radiology. We use you have a good idea whether, after seeing that, whether it is acquired or a congenital bronchiectasis. If it is more on the left side and symptoms started since childhood, that's an important clue that it could be congenital. If it is on the right side and there is an insult after which the symptoms have started, though you don't have the old X-rays, it's quite possible that it's an acquired. So the site gives you a good clue. Bronchiectasis. This is the structural part. Second is the functional part. You know how much he is impaired. So you want to do a spirometry. You want to look at reversibility. You want to do a 6-minute walk test. If he is in the extensive bronchiectasis, then you want to look at exertional desaturation. You want to see whether do a cardiac evaluation, ECG, echo, BNPs, to see whether he has other problems, his dyspnea. Then we do a microbiologic one. We want to know what is the organism. I think the subsequent, it will be dealt with in more detail, but we always, before we start antibiotic, send this sputum for culture to identify what is the organism. The organism is going to give a clue as to the survival of this particular patient. So it's very, very important that we try to do that. Investigations are being done. Then you go on to do a specific investigations depending on what is the suspected cause or based on what is the most common. So every patient with bronchiectasis especially post-tubercular bronchiectasis, you must always rule out disease activity. Again, the recurrence of the disease when he comes to you with acute symptoms, because it could be a recurrence of tuberculosis and he has a post-tubercular sputum, CB-NAT, things like that. Idiopathic is only a disease of exclusion after you have ruled out other things. Immunodeficiency, people have already spoken about the need of immunoglobulins. It's important to realize that there are people who have normal immunoglobulins, but we don't do it in India. But it is important to challenge the patient with vaccine, the response of the antibodies, specific, for example, pneumococcal, for example, tetanus. These are not available in India because the levels may be normal, but they are functionally abnormal. They don't respond. So that is what you need to do for the humoral, kind of immunodeficiencies. Then if you suspect GRD causing bronchiectasis, then you can do pH monitoring, you can do a swallow test, doing an upper GI. And if you suspect a congenital disease, for example, a primary ciliary dyskinesia is so difficult, what I do is I ask for a fresh semen analysis. So the cilia in the airway and the cilia in the sperm are the same. So if the in the fresh semen looking at the motility, are abnormal. So that is a simple test you don't. Otherwise, even in Mysore University, we have a scanning electron microscope, but nobody knows how to use it. So we still face a lot of problems. If you suspect autoimmune disease, as you said earlier, we need to important, especially rheumatoid and all that are quite important. ABPA, I'm sure will be dealt with subsequently. We need to look for ABPA again as again, as Dr. Deepti said, when you have particular features, you need to look for it. Cystic fibrosis also, I'm sure, will be dealt with subsequently.
Yeah, thank you, Dr. Makesh sir. That was an extensive overview which you have given. But the important thing for all the participants here is idiopathic is something which we label when we have worked up a case of bronchiectasis. But unfortunately, what really happens in a real world scenario is we just look for very few etiologies, but we need to extensively evaluate. As sir said, you first need a proper CT scan. Then second, you need to do a functional assessment, which requires a PFT, 6-minute walk test. Then you need to get a blood investigations, which involves the connective tissue disorder workup, immunoglobulin levels, screening up for an ABPA. And the most important thing which sir touched upon is the sputum analysis. Sometimes you know that if you have a pseudomonas, your patient is going to be a frequent exacerbator, so you need to send the sputum analysis. And one very pertinent point which sir referred is with respect to the response to vaccination. This is something that is routinely done in the Western population to find out if there is a qualitative defect in the humoral immunity. So in India, we generally don't do it, but that is something I think we should imbibe from our Western colleagues to actually look for immunological causes of bronchiectasis, especially when you are dealing with a case of a childhood bronchiectasis. But one thing which we often see as a case of bronchiectasis is a retained foreign body. Sometimes doing even a bronchoscopy in a bronchiectasis patient, once you have ruled out all the potential other reasons, with a localized lung involvement still has an important role. So now I'll move on to Dr. Girija Nair, ma'am. So what are the most common organisms we routinely observe in the sputum sample of bronchiectasis patient? And does identification of certain organisms really change your prognosis and management of patients with bronchiectasis?
Yeah. Actually, we were also part of the Embark India study, which I think in 2015 to 17, like Dr. Mahesh only. At that time, again, we were also trying to look for the causes of bronchiectasis. So, and the secondary infections which were there. So Pseudomonas again was high on the list as part of the Embark study. 13% of 13.7% of Embark Indian patients had Pseudomonas infection. While I'll just give a list of that, Entero, Klebsiella, and E. coli together had around 9.8%. Staph were around 2.3% of cases. And NTM was also there. H. influenzae also very minimal cases we did find. This and Moraxella about 1% of cases. So most common of our secondary infections was Pseudomonas. ABPA also, we found many cases of ABPA in our patients because we looked for it at that time. While these were the Indian studies, European studies were, and even Western other, studies are a little different, where they found where NTM was one of the causes, or secondary infection with NTM in bronchiectasis was there in the US. So NTM is more common as a secondary infection in the US. And in Europe and all, there are more other H. influenzae and other causes. But in our country, and other, of course, Pseudomonas is always there. So what is the problem with Pseudomonas? Like we say, you have to treat it. It's difficult to treat and difficult to eradicate. The word was eradication. It stays there or something, and they do have biofilms. H. influenzae as well as this Pseudomonas, they produce these biofilms. I think that is why it is difficult to eradicate them, totally. So this is what I have to say. Pseudomonas is the most common, and that is why these patients are also frequent exacerbators. And the severity also is higher when they have a Pseudomonas infection. And one thing we must remember, it is not a single infection alone, but there could be multiple also causes, multiple organisms together being there. And the interaction between these, there was some study in Korea where they found that with every exacerbation, there was interaction between these microorganisms together who are staying there in the bronchiectatic segments. So they are also different, and so the further studies should be done to identify, which are the other microbiomes which are involved in this thing.
Yeah, thank you, Dr. Girija ma'am. So as Dr. Girija ma'am has said, the sputum analysis plays a very, very important role both in prognosis and treatment. So you need to send for sputum pyogenic, gram stain, and culture. Sometimes you have to send for sputum AFB with culture, especially to pick up these NTMs. And sometimes you may need a sputum fungus as well. So whenever you find a Pseudomonas, that is the point where you may have to actively consider an eradication regimen. And as ma'am has said, NTM is something which we often overlook, especially if you see a middle-aged women or a little elderly women coming to you emaciated, having a bronchiectasis. Always look for NTM, and if NTM is there and if it is treated, this can really change the outcome of the patient. And especially in post-TB, sometimes we always think that it's a reactivation of tuberculosis. Maybe not. Many times when you do a bronchoscopy, gene expert comes negative, AFP or culture comes positive. Later, it turns out to be an NTM. NTM is still very common. Only thing is, we need to have a high index of suspicion and probably send the samples and follow up these samples for NTM. So with this, I'll move to Dr. Mahesh. So we heard about Pseudomonas, we heard about eradication regimen. So when do you actually initiate an eradication regimen for a Pseudomonas colonization? And if so, what are the regimens available? Just one sample of Pseudomonas, is it sufficient for you to start these patients on eradication regimen, or would you like to send a repeat sample? And when do you send it, whether when the patient is in an exacerbation or when the patient is in a stable phase for to be considered as a candidate for eradication regimen?
Sir, Dr. Girija ma'am has mentioned that EMBARK study has mentioned the Pseudomonas was one of the part of microbial flora. And first of all, we should know that why is it important to consider the eradication of Pseudomonas. As Bhoti madam has also mentioned that it was a part of BSI index, facet index, because it affects the morbidity and mortality. The statistics says that the Pseudomonas colonization increases the mortality 3 times, hospitalization 7 times, and it increases the exacerbation, 1 additional exacerbation per patient per year. So Pseudomonas should be eradicated, and there is a controversy related to when to eradicate. Some mention that it should be eradicated after the first isolation, and there are the different regimens available for it, like inhaled regimen, systemic antibiotics can be used. So the inhaled antibiotics used for the eradication of Pseudomonas are like tobramycin, colistin, gentamicin, and the systemic antibiotics used are like fluoroquinolones, aminoglycoside, beta-lactams like piperacillin, cephalosporins, carbapenems, and polymyxins, etc. So there are the three different eradication regimens. Like one is an oral regimen where the oral antibiotic, especially ciprofloxacin, given for the 2 weeks. If there is a persistence of Pseudomonas, then IV antibiotic like beta-lactams and aminoglycosides, followed by inhaled antibiotic for 3 months. This is an intravenous regimen which includes the beta-lactam plus aminoglycoside for the initial 2 weeks, followed by the inhaled antibiotic for total 3 months. And there is the third regimen which contains the oral or IV antibiotic with inhaled antibiotic initially in the 2 weeks, and only the inhaled antibiotic is given for the total 3 months.
So, as Dr. Makesh has said, eradication is something which we all should know about. So, when we speak about eradication, it's totally different from treatment. Let's say that you have a patient with a bronchiectasis who come to you with exacerbation and has a pseudomonas. There, we are not speaking about exacerbation. There, you need to treat this patient for an active infection with the pseudomonas. And once a patient comes to you in a stable state, you send the sputum sample. Sometimes there are centers which send a repeat sputum sample to confirm that it is a persistent colonizer, especially in frequent exacerbated patients. And in these patients, if you find pseudomonas, then that is the point you need to consider an eradication regimen, because if not, this pseudomonas is going to keep causing exacerbations and it is going to keep causing structural damages. And as Dr. Makesh has said, you have combination of inhaled IV and oral medication. So at our center, what we do is we start these patients on ciprofloxacin along with nebulization with tobramycin. We give the ciprofloxacin. We give these antibiotics for a course of 3 months, and then we repeat the sputum sample to see if this colonization is taken care of. And so especially sometimes you may have a non-pseudomonas frequent exacerbators, then probably even a long-term azithromycin can help in preventing the colonization and can act as an effective eradication regimens as well. So with this, we move on to the next question, and that is to Dr. Kushbu. So how do you really treat a patient of post-TB bronchiectasis, and does your management really differ, and where do you really place the role of an ICS in these patients?
So, post-TB bronchiectasis is one of the most common entities that we encounter, especially when we are sitting in OPD of a government hospital. So, whenever we encounter a patient with a bronchiectasis and a history of tuberculosis in the past, I would first want to see if it is active tuberculosis or not. And also, I would want to send cultures to rule out if it is NTM or not. So, with this, there are no standard guidelines for post-TB bronchiectasis. It's a gray area. But I would treat it like a standard protocol. Airway clearance would be a mainstay in the management of post-TB bronchiectasis. Also, I would want to screen them with the lung function test to see if they are having some obstructive component, airway component or not. So, if the patient is having obstructive pattern, then probably I would want to go ahead with the bronchodilators. And also I would want to screen them for eosinophilic inflammation. If the eosinophilic inflammation is there, then I would want to add ICS to the patient.
Yeah, so as Dr. Kushbu has already said, whenever a patient of post-TB bronchiectasis comes in and exacerbations, always rule out an active ongoing tuberculosis in these patients. But as we discussed earlier, NTM do occur in these patients with post-TB bronchiectasis. But somehow when it comes to the role of the inhaled corticosteroids, most of the guidelines, for example, post-TB causing a COPD, like phenotype also, there is always a high threshold in the initiation of an ICS until and unless we generally try to avoid an inhaled corticosteroids because of the risk of reactivation of tuberculosis in these patients. So if you can control the symptoms with just a LABA and a LAMA, probably that would be the ideal one. And withholding ICS would be beneficial, especially if you are dealing with a post-TB bronchiectasis because of a risk of reinfection. So with this, I move to Dr. Deepthi Gothi, ma'am. So we have spoken in depth about most of the aspects of non-CF bronchiectasis, but one important entity of a non-CF bronchiectasis is ABPA. So what is the revised ISHAM criteria for the diagnosis of ABPA? And how do we actually classify ABPA in our clinical practice based upon the CT scan?
So I would like to say one thing, that when you're talking about bronchiectasis, I usually like to separate out the bronchiectasis from ABPA. I mean, ABPA is an entity. It's again a syndrome. It will take one or 2 hours to define ABPA and fully treat it. because it leads to a proximal bronchiectasis more often than not, HAM, etc., more often than not, maybe cystic fibrosis. I usually use a very simplified criteria, which is minimal essential criteria, and I use asthma, immediate cutaneous sensitivity, IgE more than 1000 or more than 400 Pascal unit, kilo unit, or elevated specific IgE and central bronchiectasis. And by and large, when you have ABPA, one needs to move in direction of treating a severe asthma and ABPA. Now, when you have a cystic fibrosis, which is little less common in our country, can have ABPA, but this cystic fibrosis related ABPA would be treated in a similar manner in terms of bronchiectasis. I have a very good experience with mepolizumab, all your omalizumab and mepolizumab. They work brilliantly well with ABPA, whether they have a proximal bronchiectasis or no. It is one of the very emerging treatment and really helps in a long term. So I guess I've answered your question. In terms of anything left, let me.
Yeah, I think most of the things are answered, ma'am. Just for the interest of the audience, there are certain revisions in the ISHAM criteria. So unlike the past where you take only asthma and cystic fibrosis as predisposing criteria, now you can even take a COPD or a patient with a compatible radiology. So irrespective of your underlying obstructive airway disease, it becomes a predisposing factor for diagnosing ABP. And apart from that, one area where it's still a gray zone, but the ISHAM guideline prefers is that previously we used to believe serum total IG as the screening modality of choice for ABPA, but right now they are saying the sensitivity of the specific IG against aspergillus is more than the serum total IG. So if at all you want to screen a patient for a ABPA, the ISHAM guideline says that you prefer a specific IG over a serum total IG. And another thing is the serum total IG cutoff is also like previously we used to be having a stringent criteria of 1000, but right now they say that if you have all the other parameters, you can still consider more than 500 to be a criteria for fitting these patients into ABPA. So, and as ma'am said, ABPA is a syndrome by itself. You can have a ABPA S, which means that you have only serological criteria without any radiological abnormalities, or you can have a ABPA CB, which means there is a central bronchiectasis. You can have a ABPA HAM, which means there is a high attenuated mucus plug in these patients. And sometimes ABPA is also phenotyped as one with a chronic respiratory failure, just for the sake of management. I think with this, we will move to Dr. Makesh sir. Since we are speaking about ABPA, how in your practice do you actually treat a patient of treatment naive ABPA? That means a patient comes to you and you diagnose him as an ABPA for the first time. And would you still go ahead giving an antifungal in this patient? Or so just to put it in a nutshell, you have a patient who is an asymptomatic ABPA diagnosed on screening, and you have a patient with a symptomatic ABPA. So how does your treatment actually differ?
Generally, once you have a patient, you're diagnosed, if he's asymptomatic, generally the guideline, I think a lot of work has been done by Ritesh Agarwal from PGI Chandigarh. I think he's the doyen as far as ABPA is considered, not only in India, but outside. And the recommendation is to keep under close observation, because it need not always be asymptomatic, or it can again be silently progress, and before you realize it will, the patient will present with full-blown symptom. So patient who is symptomatic, your main treatment goals would remain to give symptom relief, improve the asthma control, prevent exacerbation, make sure get maintain as best lung function as possible with the least possible side effects. Now, the choice one has is between choosing steroid. Low dose steroid is as good as high dose steroids, as study has shown, or use an antifungal. Again, studies done by Ritesh shows that both are equally good. So it depends on your comfort. Both good. We have used both. We used to use steroids earlier. Now our first preference would be using itraconazole, 400 milligram a day in divided doses. Generally, treatment will be for at least 4 months. Even prednisolone, low dose, you can use 0.5 milligram per kg per day for 4 months. for a newly diagnosed case, and then taper 5 milligram every 2 weeks, and then you try to boost. Itraconazole is shown to be as good. There are some people who will also recommend using oral steroids for first 2 weeks and then move on to high dose inhaled steroids. They also tend to add itraconazole to that also. But one should be cautious that when you're adding itraconazole, because of the impact on the liver enzymes, the side effects of steroid, even inhaled, high dose inhaled steroids also, there is a possibility of Cushing syndrome and adrenal insufficiency. So that has to be kept in mind especially when you're using both together. Itraconazole alone is shown to be as good as oral steroids now. Now, of course, along with the itraconazole, there are other antifungal. We don't use them, and these are very expensive. Voriconazole also is shown to be good, especially in cases where itraconazole has failed. Then voriconazole is also supposed to be good. There are other isovoconazole, posaconazole also can be used, but these are very, very expensive proposition. Our first choice of an antifungal is itraconazole.
So excellently put, sir, regarding the treatment of ABPA. So for the audience here, if your patient comes to you as an asymptomatic ABPA, that means they have just an asthma, you treat the asthma, you don't treat the ABPA with steroids. So only for a patient who has got a symptomatic ABPA, you choose preferably a steroid. But as sir said, there is a lot of studies which comes now say that you can choose an itraconazole upfront, but there is no role for a combination of an antifungal with the steroids for your first presentation. You use a combination of a steroids with an antifungal only if the patient is refractory to the treatment or not able to attain a remission. And apart from that, itraconazole is the preferred antifungal. But when you are giving itraconazole and steroids, it's just a clinical observation that you tend to see a lot of side effects of steroids. So because of the drug interactions. So you need to be very cautious and you need to monitor the liver enzymes whenever you are giving itraconazole. And the duration of the treatment is for 4 months. And then you repeat your PFT, X-ray, and the serum total IgE to see if your patient is responding. And you wait for at least 6 months to say that your patient has gone into a phase of remission. So in treatment refractory cases of ABPA, probably you can try experimental drugs like biologics, but biologics are not the preferred medications of choice, especially when you're dealing with a case of an ABP. So now we'll move on to Dr. Girija Nair, ma'am. So in the presentation of Dr. Deepti ma'am as well, like we saw a lot of scores associated with bronchiectasis. So what are the scores that are available to categorize the severity of bronchiectasis and how it is of clinical relevance in routine day-to-day practice?
Yeah, Deepti madam, she described it very well. Anyway, for our students especially, I would like to again tell you the two scores which are easier to use than the others. One is the FACED, that's the FACID score, and the other is the bronchiectasis severity index. Especially the FACID, it's quite easy to use, and that's what we should be using. They basically what they do is the assessment of the clinical, radiological, and the microbiological assessment, and the functional assessment is done in an eFACID. So what is FACED? F stands for FEV1, and it's easy to score. If it's less than 50%, you give it you give it 2 points, and if it is more than 50%, then you give 0 points. Age, again, if the patient has more than 70 years of age, you give 2 points, and if it's less than 70, 0 points. Then next one is colonization, is C, and whether Pseudomonas colonization is there, yes or no. And then E is the radiological extension, or so if it's just 1 to 2 lobes are involved, then it is given as 0, and greater than 2 they give 1 point. And D is FACED, D is dyspnea, which MMRC score, which you do 1 to 2 will be given as 0, and 3 and 4 is given as 1. So all this together, what we do is, you score the patient, and out of them, maximum will be 7. The first two, FEV1 and age, had 2 and 2 each maximum, and the CED had 1 score each maximum. So total would be 7. So if there was mild bronchiectasis, there it would be said as total score is 0 to 2. And moderate is around 3 and 4, and severe bronchiectasis is considered as 5 to 7. So it's very interesting for our students. Remember FACED, FEV1, so that is how the patient presents, then the age of the patient, the colonization. So clinical, radiological, and microbiological presentation. We just can divide the patient into either he has a mild, moderate, or severe. Because again, this will help in how to manage your patient, how to call when to call your patient back, frequency of and intensity of your workup of the patient. So if he has a severe bronchiectasis, then you would call him back for follow-up, at more quicker intervals, I should say. And your intensity of your management should be more. Similarly, the BSI, or the Bronchiectasis Severity Index, as again Dr. Dipti has already mentioned, but I will just tell it to you again. So it has got about 9 variables, including the age, the BMI, the FEV1, hospital admissions, exacerbations per year, then the dyspnea, which is in MMRC, whether Pseudomonas colonization is there, contamination is there or not, and then radiological severity, how many lobes are involved. And so the total maximum comes up to around 21. So more than 9 is considered as severe. So again, what this is helping out is there was a study also, and what they said was it helps to identify the degree of mortality and morbidity of these patients. And the BSI index, especially, it is a tool which helps in guiding, how the decision making and how quickly to follow up the patient. So I will just give you an example, like, mild bronchiectasis, which of the BSI, which is the Bronchiectasis Severity Index. So the score is between 0 to 4, and it's a predictor of mortality and morbidity. Okay, so 1 year and 4 year mortality and morbidity is there. The predictor is there. So 1 year mortality rate is around 0.3, is between 0 to 3, and 4 year mortality is around around, I think, let me see, 4 years, and hospitalization is around 3 months, something percent. Again, in moderate, when you find moderate COPD is between moderate bronchiectasis, score is between 5 to 8, and 1 year again mortality rate they have, and 4 year mortality rates, and the outcomes are there. So up to 11.3% is the 4 year mortality rate in moderate moderate bronchiectasis, while in severe bronchiectasis, which the score of 9 plus, is the mortality rate is high. 1 year mortality is up to 10.5. Hospital admissions are also high, about 52% hospital admissions chances there. And the 4 year outcome is again poor. Mortality rate is high, 29% in severe bronchiectasis, and hospital admissions are around 80%. So once we come to know that he's a mild, moderate, or severe, so which are the two scorings which we can use, especially is the Bronchiectasis Severity Index. It's an online tool. Okay, you can just download it, and it's an online tool. You can get the number straight away, just putting in your points, as I have said, depending on age, BMI, FEV1. And the other one, easier one to do, is the FACED, or the FACET tool, which we can use. This will help us. It will give us an overall idea regarding the clinical, the radiological, and the microbiological assessment of our patient, and how the patient is going to behave in the future. So it will help us in treating our patient.
Yeah, thank you, ma'am. And in the interest of the time, to Dr. Mahesh, so we spoke about bronchiectasis. So what are the most common complications you see with bronchiectasis? So is it only a pulmonary complication, or you can even have some extrapulmonary complications of bronchiectasis?
There are both pulmonary and extrapulmonary complications associated with bronchiectasis. One of the most,
can you be a bit louder, sir?
One of the most common complications related to recurrent infections. These recurrent infections are drug-resistant infection because of exposure to multiple antibiotics, and this may manifest sometimes with hemoptysis. If there is a mild hemoptysis, you must rule out infection and treat with the antibiotic. If it is a moderate to severe hemoptysis, it may require an further evaluation with contrast NSCT with angiography. And this moderate hemoptysis can be managed with bronchial artery embolization. However, the life-threatening hemoptysis may sometimes require bronchoscopic closure or the surgical management. Again, recurrent collapse related to thick mucus in bronchiectasis patients, and it can be managed with postural drainage, physiotherapy, hydration, mucolytics, mucokinetics, and at times, if a big lobe or is involved with respiratory failure, it may also require a bronchoscopy. There are some therapy-related complications like antibiotic use, like macrolide. The long-term macrolide may cause cardiac issues, like it may prolong QTC. There are multiple drug interactions. It can even lead to a hearing loss, or it can cause vestibular issues. Plus, these inhaled antibiotics which are used, it may cause a bronchospasm, and it can be managed with a prior bronchodilator before giving an inhaled antibiotics. In cystic fibrosis related patients, patients can have intestinal obstruction or the pancreas related issues. And like inhaled corticosteroids increases the chances of NTM infection in bronchiectasis patients. And whenever we use itraconazole or steroids in ABPA, so itraconazole related GI intolerance, liver derangements, then peripheral neuropathy, QTC prolongations can be seen. And some of the sequelae of bronchiectasis like respiratory failure, pulmonary hypertension, right heart failure, amyloidosis can also be seen.
Yeah. So excellent overview, Dr. Mahesh. So whenever you speak about complications, always remember about the extrapulmonary complications as well. And hemoptysis will be a life-threatening. And as Dr. Mahesh said, you may have to consider embolization or even a lobectomy in severe cases. So moving on to Dr. Kushbu. So how do you really manage a patient who presents to you with an acute exacerbation of bronchiectasis? What is the line of management in those patients?
So, to stabilize this respiratory failure, if oxygen therapy alone doesn't work, I would go for, and also it is recommended to go for NIV along with the humidification. And most common causes for exacerbation are usually infectious. So treating the infection and providing adequate airway clearance therapy is the mainstay for the treatment of acute exacerbation, along with the taking care of other comorbidities like diabetes, cardiac issues, any pulmonary hypertension if it is there. So everything as a whole we have to manage. Bronchodilators does play an important role for the management of exacerbation of bronchiectasis. And also with that, I would want to mention the particular sequence of nebulizations that we have to follow. Like while whenever you are giving nebulizations to sorry, you are giving mucoactive agents to any patient. If a patient is having hyperreactive airway disease, so first we have to go for nebulization with the LABA and followed by nebulization with hypertonic saline or other mucoactive agents, followed by the nebulizations with ICS if at all required, and LAMA. So this is how we would manage the acute exacerbation, treating the infection well, sending the cultures properly, and preferably before giving antibiotics to the patient, and going for the treatment likewise.
Yeah. So the most important thing, what Dr. Kushbu said is, one, you have a medical management. Yes, you are going to start bronchodilators, you are going to start mucolytics, you are going to give antibiotics. But the most important thing is humidification and airway clearance technique. These are something which is pretty much neglected in an ICU setting. The patient is put on NIV, but never made to expectorate. So the patient retains all the secretions, causes dead space ventilation, increase CO2, and patient eventually gets intubated. So if at all you are putting your patient on NIV for an acute exacerbation of a bronchiectasis, make sure you continue aggressive chest physiotherapy. Make sure you remove the mask in between, put them on a high flow nasal cannula also if required. Make them expectorate. Until and unless you do this, your patient will deteriorate on NIV despite receiving the best of the medical management. So this brings us to the next question to Dr. Deepti Gotiman. So we have spoken in depth about non-cystic fibrosis bronchiectasis. So when it comes to cystic fibrosis, when do you really suspect? And apart from cystic fibrosis, are there any other etiologies of a childhood bronchiectasis?
So one thing I would like to make it very clear is that cystic fibrosis has been reported even in 6 decades. So only because you have a patient in adult life, it does not mean that it rules out cystic fibrosis. I have seen a couple of patients, in fact 3, 4 I remember, of cystic fibrosis in adult life. they actually start having presentation. So always keep in mind, because cystic fibrosis is treatable now. Once diagnosed, can be treated. One needs to find out when you are suspecting, or any bronchiectasis case, I always ask for sibling death, consanguineous marriage, GI complaints. They say GI complaints for cystic fibrosis is bulky stool, and that for immunodeficiency syndrome is a watery diarrhea. So GI complaint is an important aspect. Of course, atopy is another very common finding with cystic fibrosis, not so common with the other disorders as such. Post-infectious may also present in childhood. So, it's not that if you have a adult, then it is not cystic fibrosis. If you have a child bronchiectasis, then it is cystic fibrosis. No, it can be one way or the other. Primary ciliary dyskinesia is one thing which I earlier also said that can be easily missed, and one needs to investigate in terms of nasal mucosal biopsy. Electron microscopy is something which is most essential part of it. Very few centers do it. I know in Mumbai, Hinduja used to do it. So many places we need to sensitize the his pathologist about electron microscopy. So cystic fibrosis, sodium sweat chloride test, and delta 508, PCD when you are suspecting, nasal mucosal biopsy clinches the diagnosis. In childhood, apart from these two, you can also have post-infectious and ABPA. Munirpun, though it is considered to be an inherited cause, it usually presents in adults. CTD again presents in adults. Alpha-1 antitrypsin again presents in adults. So these are roughly the adult and childhood. I hope it answers your question.
Yeah, excellent, ma'am. Excellent inputs. And Dr. Makesh, sir, so when we have cystic fibrosis, what is the study you do, and how does your genetic studies actually impact your treatment, and what are the current treatment options available?
All right. For cystic fibrosis, what we do is, it is important to have a multidisciplinary care. You need to have your nutritionist, you need to have a specialized physiotherapist who is well trained to handle these difficult cases along with the pulmonologist. So you need a multidisciplinary care. One, the first thing you need to do is to see whether this patient has Pseudomonas or not, because as you said, that's the most important, that looks at the outcome of these patients. The how to treat has already been dealt with. But if there is a chronic Pseudomonas infection, treatment has to be alternate month and lifelong. As again, Dr. Deepti said, physiotherapy is very, very essential. You can give a postural drainage. Now you have PEP therapies, flutter valves available in India, and that is found to be superior to which is much more expensive. Regular postural drainage does not need any equipment, but if you have a PEP therapy, it is very useful. As far as mucolytics are concerned, only the ones that act on the DNA, the Dornase alpha is useful. None of the other mucolytics are useful in cystic fibrosis. They are not useful, including only that Dornase alpha is useful. Hydration, as you said, is critical. There are two things to do that of the airway lining fluid. One is the hypertonic saline, 7%. It has shown to improve lung function. In a systematic review, it has shown to reduce exacerbation, and therefore it is critical. Or people have also used mannitol, which is also shown to improve lung milligrams daily as a capsule. Dry powder inhaler is available, and that can be used. Macrolides are important. Not only it is not for infection, it is for inflammation. And macrolides are shown to be a biofilm disruptor. So for Pseudomonas, using a macrolide seems to be an important part to be added. And specifically for cystic fibrosis, look at CFTR mutations. There are more than 2,000 of them. They divided into 6 classes. The most severe one is where there is no CFTR protein at all. It is 0. So these mutations will lead to a stop codon and nothing happens. And therefore, it is It is quite important. No, these cannot be treated. Now there are others where you have it is read properly. It is not moved into the cell surface properly. It doesn't open properly. It doesn't function properly. This is where we have two drugs which has shown to be quite good. Ivacaftor is one, which is a CFTR potentiator, and which is specifically you need to look for a gating mutation, C55-1D, and that's where it is maximally useful. And then you have which is the corrector of the intracellular trafficking of the CFTR to the cell surface. And this is also shown to improve lung function, shown to reduce exacerbation. And this is most useful when patients have the typical delta 508 mutation. So then there are people with both the mutations, and then you can use both the drugs together. So looking at airway inflammation and use of even high-dose ibuprofen have been tried in children specifically. Thank you.
Yeah, excellent, sir. That is like putting everything in a nutshell. So the take-home point for people here is, apart from all your standardized therapy for bronchiectasis, when you diagnose cystic fibrosis, you have certain specific therapies for which you need to do a genetic study. But unfortunately, we do get these drugs in India, but it is exponentially costly, and continuing the treatment becomes very difficult for the patients. But if at all your patient is affordable, you still have access to these drugs on a compassionate grounds. And to Dr. Girija Nair, ma'am, how commonly do you say bronchiectasis with NTM? We did touch upon this, but once you diagnose an NTM-associated bronchiectasis, how do you really treat them?
Yeah, one thing we must remember that even NTM they can be even contaminants in the water. So when we do our bronchoscopy, I remember long time back when we did a lot of bronchoscopies, we found NTMs coming up. So, but they were because of the contaminated tap water in our bronchoscopy. So that then later on when we started using the RO and all the we.
Ma'am, we are not able to hear you, ma'am.
Country, I find around 3 to 5% of the cases of bronchiectasis being of NTM. NTM could be the cause of the bronchiectasis, or it could be a colonizer also. So again, out of them, again, rapid growers it's again what happens is our patients cannot afford to go for speciation. Once they identify that it's an NTM, they ask for a species identification. Many of our patients are unable to pay for that species identification, so we can just generally go about the treatment of that by either giving them most of them generally.
I think there's a network issue. Ma'am, can you hear us? Yeah.
Yes.
Now we can hear you. Yeah.
Yes, yeah. The rapid growers, if they are there, the rapid growers are the one fortuitum or abscesses, which are quite common when we see them. So we can give them generally clarithromycin, amikacin, and maybe tigecycline and imipenem, maybe even use moxifloxacin. Otherwise, as a general for our we can rifampicin, ethambutol, and azithromycin, as a macrolide, azithro or clarithromycin is good for even for Kansasi. And streptomycins we can give them, or kanamycin. So as a general, if we are not able to identify the species, we can give a general treatment for NTM, or we can go for species identification and treat accordingly. Again, MAC. So we are finding, in fact, we find fortuitum, we find the rapid growers more, abscesses, a few cases of MAC we have found, and Kansasi among the lot of NTMs that we have seen.
Yeah, excellent, ma'am. And for the audience here, NTM isn't that uncommon. So if at all your patient is having prolonged asthenia, loss of weight, loss of appetite with the bronchiectasis, always send the sample for an NTM. And as ma'am said, you need to do the speciation. And for most of the cases, you start them with rifampicin, ethambutol, and azithromycin. But azithromycin resistance also should be looked into it. And the important thing is, when you see an NTM, it doesn't mean that it's NTM. It can be a colonizer. So always take into a clinical picture, look into radiological progression. And only if it fits, then probably you are dealing with a case of a pathogenic NTM, which may require a particular treatment. Now, moving on to Dr. Mahesh, what are the airway clearance techniques that should be advocated to the patient to enhance their mucus clearance? So, what do you really do in your clinical practice? Dr. Mahesh, you're on mute, please.
For the airway clearance technique, the counseling is most important because most of the patients are behind taking some kind of therapy and they don't realize that this physiotherapy or this kind of airway clearance technique are one of the most important pillars of the treatment. So as we know, the one therapy doesn't fit all. We have to use a different kind of techniques. And I always involve the physiotherapy in my management because they know exactly which lobe to be drained, how to drain, and they have consistently doing it with different kind of devices as well. Some of the important factors to increase the clearance of the mucus is like hydration, muscle strengthening exercises, and it should be supplemented with inhaled bronchodilators, mucokinetics, mucolytics, hypotonic saline, etc. And we must give an importance to an anti-muscarinics because this anti-muscarinic has a side effect of dryness and it should be addressed clearly to the patient. And then some techniques like a postural drainage, it gives a gravity-dependent positioning. The mucus is cleared, secretions are cleared, and it depends on which lobe is predominantly involved. Some expiratory techniques like a slow expiratory technique like autogenic drainage. And this autogenic drainage usually it's based on the equal pressure point, what we learn in the pathophysiology of COPD. Then force techniques like active cycle of breathing technique, and there is a cyclical different techniques like breathing control, then deep breathing followed by and forced expiratory technique like huffing, and these cycles are continuously done. Then some of the instrumental techniques like PEG devices like PAPE mask, T-PAPE, some oscillatory PAPE devices like a flutter, a cappella, aerobica devices. There are a few things available like high frequency chest oscillation machines, and this really augments the puffing out the sputum. Then some cough assist devices which really mimics the natural cough like Philips machine is there. Then and this airway clearance technique should be supplemented to a pulmonary rehab technique like aerobic training, physical training, as well as the muscle strengthening exercises.
Excellent, Dr. Mahesh. So the role of a pulmonologist extends beyond the pulmonologist per se. So you need to be a very good physiotherapist as well when you deal with a case of bronchiectasis, because most of the physiotherapists unfortunately do not give so much importance for the postural drainage and other things. I think we as pulmonologists should take the role and do it. And as we speak about airway clearance technique, over to you, Dr. Kushbu. So what is the role of the mucolytics and how do you actually choose them? You have a lot of mucolytics. You have hypertonic saline, you have N-acetylcysteine, you have iridocysteine, carbocysteine, so many mucolytics in the market. So how do you actually choose them and what is the role in bronchiectasis?
So mucolytics do have an important role in airway clearance techniques, especially in the patients who are unable to expectorate out their sputum, and when the sputum is really thick and tenacious, and it makes it difficult for the patients to bring it out. Also, as I had already said, whenever we are administering mucolytics, we should give a nebulization with LABA to avoid. So these mucolytics, they have a tendency to cause bronchospasm in certain patients, especially when they have the lung capacity is low. So rather than that, to avoid all the risk factors of bronchospasm, one should always give a bronchodilator prior to mucolytics. My preference there is no head-to-head trial amongst the mucolytics which is better and which is not. Usually my preference is towards normal saline, as I have seen lesser incidences of bronchospasm with the normal saline nebulization rather than going for hypertonic saline or ambroxol. Also, I would just want to mention, although we have multiple choices, but the availability of certain agents is restricted and not available in India, like Dornase alpha, as Mahesh sir has already elaborated in detail. So this is what I would rather go for normal saline or maximum hypertonic saline for the purpose of mucolysis in patients with bronchiectasis.
Yeah, true. Few of the molecules are still unavailable in India. So with this, we'll, in the interest of time, we'll go to Dr. Deepti Gothi ma'am. How do you really treat a frequent exacerbator type of bronchiectasis patient? So what are the special medications and regimens you follow to bring the exacerbation under control?
So frequent exacerbators are the ones which are either eosinophilic variety, or they are the ones which have colonizer variety. One has to be very clear into what we are dealing with. One thing for sure is that chest physiotherapy and postural drainage remains the center point of whether it is an eosinophilic variety or pseudomonas variety. Postural drainage is important, vaccination is important. One has to make sure that which variety you are dealing with. And if you're dealing with a pseudomonas, then there is a very clear-cut new meta-analysis which has come up recently. And as per that, one needs to, this meta-analysis has been published in one of the chest, I think one of the chest article, which basically mentions that you have to give 2 weeks of inhaled antibiotic, 2 weeks of systemic antibiotic followed by 3 months of inhaled antibiotic. 2 weeks of systemic antibiotic based on the culture sensitivity, and 3 weeks of inhaled antibiotic, which covers usually gram negative like gentamicin, colistin, or any of the available as per your local needs. But these antibiotics, once given after 3 months, one has to repeat the sputum examination. One also can give azithromycin, but I would really prefer inhaled antibiotic like tobramycin or gentamicin over any other antibiotic for 3 months. So, yeah.
And even long course azithromycin as we do for
yeah, for neutrophil, yes, neutrophil variety, long course 3 months of azithromycin would be useful. The newer drug like cathepsin inhibitor, which is going to come in the market very soon, would be useful when it comes. Phase 2 trial is completed. But so far as we have, whatever we have is eosinophilic. One can even give IL-4, IL-5 variety, anti-IL-4, anti-IL-5 for your eosinophilic variety. But yeah.
So, in the interest of the time, we are moving to the last question for the day before we take the questions from the audience. So, this is to Dr. Makesh sir. So, what are the role of biologics? Because we are seeing certain data on biologics even in bronchiectasis, and what are the emerging therapies you see that we will see in near future in the management of bronchiectasis?
See, as far the role of biologics are studied for ABPA. We don't have very strong data for other bronchiectasis, though theoretically it may be useful. For ABPA, as has already been discussed, I don't want to go through it again, the anti-IgE, the MEPO, the Bendrali, the Dupi, as well as the newer one, the tezepelumab. Especially it is found to be useful in neutrophilic inflammation as well. Have all been tried in ABPA. Which is an anti-Pseudomonas bispecific human monoclonal antibody. And in Pseudomonas colonization, this may, over a period of time, gain traction. Then, as far as you have inflammation, it has already been dealt with. The DPP1 inhibitor and the cathepsin C inhibitors, these are useful, and they've already been dealt with and have shown good results. And then there is something called as ARENA-1, which is a combination of bicarbonate, glutathione, and ascorbic acid, and especially for cystic fibrosis. This is undergoing trials and found to be quite useful. Ones for infection, there is something called dual-release ciprofloxacin, which is actually a liposomal, both free ciprofloxacin and a liposomal ciprofloxacin, which will be released over 24 hours. So it's an inhaled variety that can be used. Then there is a role for, there is something called a small gramostin, which is basically a GM-CSF, and that is also found to prevent chemotherapy. But now it is also seen to be useful in patients with bronchiectasis.
Yeah. True, sir. So we may see these biologics in the future. And with this, I think we'll start taking the audience questions in the interest of time. So, Mrs. Aditi, do you have any of the? Okay, we have a question from Dr. Vaibhav. So, what is the time gap between the insult, that means tubercular infection or a childhood infection, and clinically developing bronchiectasis? So, Dr. Kushbu, do you want to take it? What is the time gap between the insult? Are you there? So if ma'am is not there, so I think there is no defined timeline. There is no way you can define timeline. It depends upon the severity of the insult, probably. So if you have a
answered most, actually. I've answered most of them.
yeah. So,
I'm just sitting and not doing anything, so I thought I will answer.
There are a lot of questions Dr. Deepthi has already answered in the chart.
yeah, I think most
I mean,
of
in
it
the
are answered. So any new questions,
So,
Mrs.
any
Aditi?
new
So
questions
if you have any new questions, we'll take it up. I think we have
No, sir,
covered
these are
most
the
of it.
questions that I've posted and ma'am has answered most of them.
So I think everything has been answered for the audience. And just in the concluding remarks, like I would like to start from Dr. Makesh, sir. If at all you want our audience to take home something from the end of this discussion, what would be your key take-home message? A one-liner from each one of you.
The most important, never forget postural drainage. I think I took off
true.
slide. I think the older people definitely make sure that every patient undergoes postural drainage. Without it, nothing works. You can give the best antibiotic, doesn't work.
True, very true. And Dr. Girija Nair, ma'am, your take-home message for the audience?
Yeah, once we diagnose a case of bronchiectasis, dilated bronchi, we should just be able to identify what is the cause of that, So childhood infections are also one of the commonest, maybe because of the, a lot of pollution and whatever it is, or repeated childhood infections. So that is one of the more, I think, important causes also. So be able to find out the cause. ABPA is one thing, we try to rule out ABPA also in our patients. So try to find out the phenotype and the cause, etiology of it, and try to treat them that way. Of course, postural drainage physiotherapy is very important for that. Yes.
Yeah, and Dr. Makesh, anything from your side? I think we lost Dr. Makesh and Dr. Kushbu. And Dr. Deepthi ma'am, one final word from you to the audience on bronchiectasis.
I would say that when we use the word bronchiectasis, one needs to use it very responsibly, not just the permanent dilatation, the clinical syndrome associated with it, and how severe is the clinical syndrome. More importantly, what is the exact phenotype the patient has, what lobe is involved, whether frequent exacerbator, what kind of hypersecretions, whether it is eosinophilic inflammation. One needs to look at the disease holistically and in the whole severity as well as the clinical phenotype.
Yeah, excellent. I think Dr. Mahesh is online. So what do you want to say? One last word for the audience here.
If it is a localized bronchiectasis and you have ruled out most of the things, do not forget to do bronchoscopy.
Yeah. So I think we have come to the end of this session here, and we had very good insights from all the panelists. And if at all I need to sum up a bronchiectasis, it is a syndrome. So, and you treat the treatable traits as we do for any other disease, and identifying Pseudomonas is of paramount importance, and always go for eradication of the Pseudomonas rather than just treating with a short course antibiotics and making the patient more prone to exacerbation. Airway clearance technique, mucus drainage forms an integral part of bronchiectasis, and your treatment is never complete without that. Always vaccinate these patients because they are more prone to develop infections. Look for pulmonary and extrapulmonary complications and start treating them. Nutrition plays a very, very important role in bronchiectasis. And when you have a childhood bronchiectasis, a strong family history, a detailed clinical examination, and if required, go for sperm analysis in unidentifiable cases of bronchiectasis, especially you are diagnosing primary ciliary dyskinesis, because it can present even in adults. CVIDs can present in adults. Look for recurrent infections in the past and ask for their exacerbation history, treatment with antibiotics, because you may have to choose a proper antibiotic for a current exacerbation. And you become a better physician treating a bronchiectasis more than a better pulmonologist. So you need to have a physician insight and do not limit ourselves to the lung. So with this, I'd like to thank Lupin for sponsoring this event, and Mrs. Aditi for taking extensive efforts in making sure that this presentation went off well, and once again, kudos to the entire team of ICS led by Sandeep Salvi sir, Dr. Rajadhar, and Dr. Amita Nene, and for all the delegates who had given a patient listening. We hope that this webinar catered to your needs, and maybe the next bronchiectasis patient you will be able to treat in a much better way. Thank you one and all, and thank you to all the panelists for sparing your time.
Thank you.
It was wonderful moderation, Vishwaswaran sir.
Thank you, Mahesh. How are you? All good?
All good, sir.
Really sorry, sir. My baby was crying in on top of his lungs, so I had to mute it.
Absolutely no